Assalamu alaikum. Good morning, good afternoon, good evening, depending on your time zone. I hope everybody is doing great. Today we are going to cover one of the commonly tested topic in the licensing exam, which is uh, shortness of breath. All right. So in shortness of breath, all right, good. So today's plan is um, what do we need to do if we have a station and we are dealing with a shortness of breath? So we have to know about the ABC, the red flags, very important. Please do not forget about the red flags when it comes to any condition, especially if it is shortness of breath. What are the immediate actions? And remember, when you know that these are the immediate actions, please speak up. So don't think that the examiner knows that I know. So you have to speak up. Must not miss causes of dyspnea. So you need to cover that part, which in today's plan is to cover it. Target history, exam, and high yield investigation, syndrome-based management, dispositions, and differential grade to score high in the NAC OSCE. All right, so OSCE first minute safe plus scoreable. So your goal shows safety, structure, and urgency. So when you're dealing with the station, so the most important thing is safety. When we talk about safety, what do we mean? Is it our own safety, our team safety, or it is patient safety? Always your first safety comes first. For example, if you have somebody who has shortness of breath and at the same time the patient has discharge, for example, sputum, vomiting, if the patient has diarrhea, any sort of discharge, so your safety comes and your team safety comes first. So if you're dealing with any type of discharge, before you start doing anything, you would ask the examiner that I would like to have protective gears for myself and for my team for our safety. When I'm mentioning safety gears, I mean gloves, mask, gowns, all those safety stuff. Okay. Now, if the patient has only shortness of breath but no discharge, or it's not infectious, the patient is not coughing, and it's not suspicious that it's going to be infectious, then it is about the safety of the patient. So your safety comes first. If anything infectious or any discharge coming out of the patient's body, whether it's sputum, vomiting, and so on and so forth. Good. So the next one is the safety of the patient. So your safety and your team safety comes first. I'm insisting because if you have the station with any sort of discharge or suspicious of infectious or disease, so you have to make sure that you mention for my safety and my team safety, I need the safety gears. And then about the safety of the patient. For the safety of the patient, I have to make sure the patient is breathing, the patient airway is okay, the breathing is okay, circulation is okay, and the patient is able to speak, and the patient is mentally stable. And obviously the vital signs, if it is given, good. If it is not, you have to make sure that you ask for it. I need the vital sign. If the examiner has it, will give it to you. If not, he will say like everything is normal or do it yourself. Okay. I doubt it if they ask you to do it because that's waste of time. Give oxygen. That's important when you're dealing with the shortness of breath. You mentioned giving oxygen only the patient if the patient is hypoxic. Titrate to target saturation. If suspected CO2 retainer or retention, COPD, target the oxygen saturation between 88 to 92%. Escalate early if severe. How do we escalate it? With a non-invasive ventilation, CPAP or BiPAP, plus airway backups. Must not misdiagnose. So these are the things if you have any station with shortness of breath, you cannot miss these conditions. For example, anaphylaxis, angioedema, foreign body, upper airway obstruction, severe stridor, breathing, for example, severe asthma, impending respiratory failure, tension pneumothorax, pneumonia with the hypoxemia, ARDS, circulation pulmonary embolism, acute pulmonary edema, which in details we will talk about every single one of them, acute heart failure, acute coronary syndrome, malignant arrhythmia, metabolic disorder like diabetes ketoacidosis, metabolic acidosis, air hunger, severe anemia, major bleeding, neuromuscular failure. So if the patient is unstable, I will start the treatment first. I do not waste the time for doing the test. Okay? So remember, these are the red flags. So you have to make sure that you rule out all these conditions. Otherwise, you're going to be in trouble or you will lose a lot of mark. So focus history, high yield questions. We will go through all the details about taking history when it comes to shortness of breath, because shortness of breath, it does not only happen in asthma, it could happen in pneumonia, it could happen in heart failure, it could happen in COPD, it could happen in, for example, let's say anemia, right? Severe anemia. But in every single one of them, we have a general approach, then we have a specific approach, which we will do it one by one. But in general, the most important thing that you need to cover for the history taking is to know how it starts, the onset. It really helps you to kind of know or categorize a few things. Like out of all those red flags, out of all those differential lists that you have, it helps you to come up at least or suspect at least 2 or 3 out of like 12. For example, if it is sudden, the shortness of breath started sudden within minutes and hours, then you think about something like pulmonary emboli. It could be pneumothorax. It could be anaphylaxis because it happens in a seconds, right? The least it will happen within minutes to hours, but usually it's very quick. Arrhythmia, acute pulmonary edema, and also asthma. Asthma could be here too, which I forgot to put it. But hours to days could be pneumonia. Again, it could be asthma, it could be COPD exacerbation, heart failure. But if it is weeks to months, usually it is more leaning toward anemia, malignancy, or interstitial lung disease, or deconditioning. Now, the key symptoms, these are the most important thing to find out before you enter to the station, because these clues help you to pinpoint what am I dealing with in this station. My patient has shortness of breath, but what are the other clues that make you suspect about certain condition? For example, if you see anything in the scenario, any symptoms like pleuritic chest pain, hemoptysis, then you think about pulmonary embolism or pneumothorax or pneumonia. If you have orthopnea or paroxysmal nocturnal dyspnea, then think about heart failure or pulmonary edema. Now, if you have wheezes and atopia, and then you have the triggers, whether it is pollen, whether it is dust, or any sort of like plants, then you think about asthma. If you have a patient who is heavy, a smoker, and has long history of smoking, and the patient has sputum and shortness of breath, then we think about COPD. If we have fever, cough, sputum, then we think about pneumonia or sepsis, anything that has to do with the infection. Throat tightness or hives plus GI sign and symptom. Obviously, it could be allergy or anaphylaxis. So these are the clues that you need to look when you're reading the station, the scenario before you enter to the station. Now, focus physical exam show the examiner you are safe. So when we have like a general inspection, and generally we check for the vitals, like if the patient is distressed, if the patient is using the accessory muscles, and also the vital sign, which usually they will provide you. For the chest, when you do the auscultation, if you hear the wheeze, you speak out up. You say that I hear wheeze, so it makes me to think about asthma and COPD at this point. It doesn't mean it is. At this point, my suspicion is more about or toward asthma and COPD. So you need to verbalize it. Crackles. I hear crackles, but so it means that I'm thinking about pulmonary edema and pneumonia. Unilateral decrease air entry, so pneumothorax, stridor, usually the upper airways affected. Cardio, class leg, jugular vein pressure, edema, and S3 positive. Rhythm, arterial fibrillation, DVT signs, unilateral swelling of the calf or lower extremities. So the red flags say them: silent chest, exhaustion, altered mental status, hypotension, cyanosis. So urgent escalation to non-invasive ventilation, air support. So if you have silent chest, if you have exhaustion, altered mental status, hypotension, cyanosis, urgent escalation, if you don't, if you do the physical examination and if you do not report this, it means you're losing mark. Why? Because you need to make sure that the patient is safe. If the patient is not safe, so what is the next step for you? So if it is silent chest, the patient is exhausted, and the patient altered mental status has altered mental status, the blood pressure is low, the patient has cyanosis, so you don't have to waste your time doing anything. You need to start the treatment right away. So you have to act quickly. If the patient is okay, then you report that the patient mental status is okay, the blood pressure is okay, I don't see any sign of cyanosis, and the chest is moving normally. So the patient does not look under any distress. So these words that you mentioned saves you a lot of mark. It means the examiner knows that you just ruled out the emergency. And in OSCE one-liner template, this is a 2, 3, 4, 50-year-old patient with 2, 3 hours of hours per day of dyspnea with this and that symptoms. Vital shows this and that. My top concern are asthma, COPD, this and that. I will stabilize the patient and order XYZ. So this is how you communicate. Initial investigation, pick high yield, not random. So for anyone who has shortness of breath, if it happens that you're dealing with the management and investigation, so these should be on your list, on top of your list, like ACG. Why do you do the ACG? Then justify it. For the ischemia, for arrhythmia,
This
right?
habit that you are sustaining like this, what should
I don't know why Agnes joins late and always her mic is on. But anyway,
I'm sorry.
keep the mic off, please.
I'm sorry.
All right. Chest X-ray. Why do I do the chest X-ray? Because I want to see if the patient has pneumonia. So I'm ruling out the pneumonia. I'm concerned about edema, pneumothorax, effusion. Why do I do the CBC? For ruling out anemia, for ruling out infection, electrolyte disturbance, creatinine, glucose. The VBG and ABG if severe distress, altered mental status change, or suspected hypercapnia or acidosis. So these should be in your list when you're dealing with shortness of breath. Okay. Condition direct test order with a purpose. So these are not the thing that you need to worry about because they're not going to go deep in details in this one. Okay. We're going to skip this one. Pulmonary emboli, again, they're not going to ask you about this one because most likely they will ask you what is the best. What is the best? The best is going to be CT pulmonary angiography. Usually they used to use the pretest probability, but nowadays they don't normally use it. But anyway, this is how you do the Wells criteria and also common cause for the pulmonary emboli. Now, syndrome-based management, it's exam-focused. So for the asthma, SABA plus ipratropium bromide, early systemic steroid, IV magnesium if severe or incomplete response. If it is COPD, which today we might do some cases, target the saturation between 88 to 92 if the CO2 retainer or retention. SABA, SAMA, steroid plus antibiotics, consider non-invasive ventilation. Acute pulmonary edema, heart failure, again, the NIV, high flow of hypoxemic, IV diuretics, nitro if systolic blood pressure is over 100. For pneumothorax, I doubt it if they gave you this scenario because this is very emergency. Probably they might give you an X-ray of a tension pneumothorax and they will tell you, what do you do? Immediate decompression. So as soon as you say this, you're good. Sometimes in the station, they might give you a scenario about, let's say, asthma. But before you leave, they just hand you an X-ray of pulmonary tension pneumothorax, for example, or pulmonary embolism, something like, let's say, tension pneumothorax, because it's very short. You can do it within 10 seconds. So they gave you this X-ray. What do you see in this X-ray, and what is your management? So this is tension pneumothorax. We have to do an immediate decompression. Good, you can leave. So sometimes it happens to have one station, but at the end, they're going to hand you something. And they just ask you one question, whether it is an X-ray or whether it is just an ECG. Okay? It could happen. Anaphylaxis, we all know how to deal with that. I am epinephrine or EpiPen, pneumonia, oxygen supportive, antibiotic when likely, sepsis pathway. Very commonly tested. Or they might just give you an X-ray of pneumonia and they ask you what is your treatment or what is your diagnosis based on all the sign and symptom, and now you have an X-ray. So based on the history taken and X-ray, what is your diagnosis? So score points for COPD exacerbation, high yield NAC OSCE. So I think we have a better slide. I'm going to just move on. Most of them was mentioned. I have a better slide. Acute pulmonary edema, start these in parallel. So NIV, high flow oxygen, if hypoxemic, we did talk about this one as well. So scoring language, I will use oxygen. NIV for hypoxemia and avoid unnecessary oxygenation in normoxemic patient. Remember, for anyone with shortness of breath, they have to be hypoxic to start oxygen. We don't randomly start for everyone. For everyone, we don't do that. So you have to mention it. And that gives you mark. And they want you and they expect you to verbalize that. This is the shortness of breath, and the patient oxygen saturation is normal. Do you start oxygen? No. Since the vital signs are okay and the patient saturation is okay, so I do not start the oxygenation. So clue and support acute pulmonary edema, orthopnea, Again, we did talk about this, which shows the heart failure, pulmonary edema. So disposition, admit versus discharge. So in which condition we have to admit the patient and which condition we can discharge the patient. Persistent hypoxemia or rising CO2 or acidosis. Hemodynamically, the patient is unstable or patient is in shock. Need for non-invasive ventilation or IV therapy or frequent bronchodilator. Then I have to admit because the patient cannot have it at home. High-risk pulmonary emboli, ACS, heart failure, significant comorbidity. Poor support, unable to follow up safety. So discharge only, vital stable, oxygen at the baseline or room air, clear diagnosis, improving with the treatment, reliable follow-up, clear return precaution, appropriate prescription, inhaler technique, and review if applicable. So the technique is very important. Before you discharge anyone, you need to make sure that they know the right way or the proper way of using the inhaler. I don't know if you guys have watched, there is a very popular TV show called House or The House, I think. So there was a female that she was complaining that the medication is not working for her asthma. And when the doctor asked him, how do you use your inhaler? And she did like puffed it around her neck. So make sure that they know the technique, educate them how to use it properly to get the best out of that inhaler. Okay, very important. If you don't use that, if you have a consultation station and if you do not insist on or do not mention anything about the techniques, you lose a lot of mark. A lot of marks. So basically, the whole consultation station is divided into three parts. And the last part, which is like 35 points, I think it is above 30, it is 37% of your score. So if you don't mention that, you lose a lot of mark. All right. So in terms of differential diagnosis, again, the typical onset for the asthma is minutes to hours, but it could be hours to, it could be more than that as well. Minutes or hours to days. Triggers, very important. The triggers, the clue, first of all, the triggers. Triggers could be anything, could be just cat, could be pet, could be something new that they brought into the house. It could be as simple as a new pillow, a mattress, a carpet, a plant, anything. Atopia or history of atopia if the patient has wheezing, prior response to inhaler. So these are all the clues about asthma. And for COPD, hours to days, remember, usually if they want to test you on this one or they want to give you a case of COPD, usually they give you a scenario about somebody that who is heavy smoker or has a long history of smoking. And if it is exacerbation, the sputum would be increased. Infection trigger, COPD retention. An acute heart failure, minutes to hours, autopnea, and paroxysmal nocturnal dyspnea, edema, crackers, and S3. Pulmonary emboli, sudden pleuritic chest pain, risk factor, tachycardia, and DVT sign. Pneumonia, hours to days, fever, cough, sputum, pneumothorax, sudden pleuritic chest pain, unilateral decrease in air, anaphylaxis, we know. So Nakoski script, what to say, opening, I'm concerned about your breathing. So I will check your vitals and oxygen level now, start oxygen if needed, and assess for the urgent cause while we talk. So for shortness of breath, this is the opening. I'm concerned about your breathing. I will check your vitals and oxygen level. See, you indirectly mention for the examiner that I know that I don't have to start oxygenation for everyone who comes with a shortness of breath. I have to make sure that they are actually hypoxic, then I will start the oxygenation. And I'm concerned about the shortness of breath that he or she has. And I check for the vital sign, I check for the oxygenation. If he or she is hypoxic, I will start the oxygenation, and assess for the urgent cause while we talk. And at the same time, while I'm taking history, I am also looking for the urgent cause. Closing, clear plan plus safety net, summarize one-liner, top three differential diagnose. You can give them as many as 5 differential, but always stick with 3 because you don't have much time to waste. State immediate treatment started. Name 3 investigation you will order and why. Disposition, return precaution, come back immediately in which case. In which case, you have to come back immediately to us or to the nearest emergency room. So key takeaway and practice. 5 exam winning message. Always start with the ABC, with the oxygenation or saturation, severity assessment. Name the life threats before you get comfortable. So once you rule out the life-threatening condition causes, then you can relax, because if you have something that's life-threatening, then it means that you need to stop and move on to the treatment as soon as possible. So this one, again, very old, but again, they might ask you about the best one, which is going to be the CT pulmonary angiography for the pulmonary emboli. COPD control oxygenation. This is if you are doing MCQ1, remember this. This might be in the licensing exam, or this is going to be a question when you're done with the shortness of breath by the examiner. Control oxygenation and maintain it between 88 to 92%. If CO2 retention is positive. Anaphylaxis, I doubt it if they ask you because everybody knows this. Rapid drill. For each scenario, gave one liner, 3 differential, 3 investigation, and the treatment. Sudden shortness of breath after long flight, wheeze, smoker, fever, autopnea, frothy sputum, hives, and throat tightness. So this is the approach to dyspnea. I think you can find it in shortness of breath if you go to the notes. So let's say that you have a station with a shortness of breath and the patient has asthma. I try to make it very fun and easy to remember. If you're dealing with asthma, let's say you have a station and your station is, it says, for example, you have a patient, a pediatric patient, and the patient has, for example, shortness of breath, wheezing, and the patient is using the inhaler and gets better, but nowadays he or she needs it more often, right? So you think that this is going to be asthma. So how should I structure it? How should I structure this station before I enter to this station? So remember, Jala asthma. Jala asthma, just memorize it. This is a mnemonic. It helps you a lot to gather all the information before you enter to the exam, station. So what is J stand for? Journey of the current episode. So in the journey, you need to ask the onset, the duration, the progression, the triggers, whether it was a viral infection, exercise, allergen, cold air, smoke, whatever it was. Why? To determine the acuity, likely triggers, inform urgency and initial management. So for the J, journey of the current condition. When did it start? How did it start? What is the duration? How is the progression? What are the triggers? Good. Now for A. So J is finished. Now for A. A stands for activity limitation. Can the child talk normally? Play, walk, feeds as usual? Any reduced in activity. Why do we need that? Because functional limitation correlates with severity. So if the patient has asthma that affects his daily or her daily life, it means it is severe enough that we can even decide to admit the patient or adjust the dosing, right? So it really affects the way we decide, or it has impact on how we decide or go about the treatment or management. Now, JAL. What is L stands for? Last similar episode past asthma history. Prior attack. That's the patient has a history of asthma before. Emergency visit. Why? Because we need to know if it is more recurrent. Admission, ICU, intubation, typical pattern and triggers. This identifies the poor control and high risk history. Prior ICU intubation is a major risk red flag. We need to know this because it gives you a lot of information. First, how bad the patient is suffering from asthma. How should I go about this? Second, how if the patient is frequently visiting the ER, what is the reason? What is the reason? Is it the patient that is not compliance to the medication, not taking the medication regularly, or there is a trigger that I have to go after and find it and remove it? So basically, again, this gives you a good idea about the severity of the condition the patient has. Now, we are done with JAL, another L. Last medication use and response. Last salbutamol or inhaler that you took. Frequency in last 24 hours. Response duration and steroid use and adherence. Why frequent reliever use or poor response suggests moderate to severe. Why do we ask about this? We just want to make sure if the patient is adherent with the medication use and if the patient is getting enough response or not. If the patient is taking it on time, it means the patient is not improving with that dosage. So you need to change the dosage. Or if the patient is not taking it on time, it means the patient is not adherent with the medication. Now, JALLA, associated symptoms, red flags, fever, vomiting, chest pain, cyanosis, lethargy, difficulty speaking, silent, chest or exhaustion. Why? Because these are red flags for life-threatening exacerbation or alternative diagnosis, pneumonia, foreign body, and etc. I have to know the associated sign and symptom to rule out the red flags. Now for H. H is home environment trigger. Smoke, vape, exposure, smoke exposure, pets, mold, dampness, dust, recent illness, weather, seasonal triggers. So basically, human environment, you're looking for the triggers. What triggered this asthma? What is the reason for triggering this asthma? Finds the modifiable exposure criticals, and so on and so forth. Okay. Now, so Jala is finished. Now we are going to asthma. So A stands asthma. A stands for allergy and atopia. Allergies, atopia, eczema, allergic rhinitis, food, medication allergies. Why? Support atopic phenotype. Comorbid atopy commonly worsens the control. So you know if the patient has allergy. A steroid history, S stands for steroid history, recent oral steroid use, when, dose, duration, repeated course, recently. Sickness recent severity. Frequent steroid bursts suggest poor control and higher future risk. So if someone who has asthma, who needs to control asthma with using a steroid, it means the patient is suffering from a severe form of asthma, and the chances of this patient to have severe asthma to the point that it might cost his life is high. So if the patient has recent ICU admission or use of a steroid, this is an indication for admission because this is a signal for severe asthma, not moderate. Treatment plan adherence. So T stands for treatment plan adherence. Asthma action plan present. Was it followed? Controlled adherence. Spacer technique and barrier. Obviously, it's too obvious. And H stands for hospital and ICU admission. So prior oxygen, IV therapy, continuous NIPS, ICU or care or intubation, how recent. If they have it, then you have indication for admission. So strong predictor for the future severe exacerbation drives escalation and follow-up intensity. So it means the chances of having another severe asthma is very high. Medication history and comorbidities. Comorbidities, prematurity, GERD, obesity, cardiac disease, sleep issues, and aspiration risk. Condition can mimic worsen wheezing and damage the treatment and prognosis. And last but not least, A, actual pattern impression. Pattern impression, how does this compare to prior episode? Is this the worst or this is better than the last episode? Often reliable severity gauge, especially when baseline is none. Helps calibrate the urgency. So if it is worse than the last time, it means that you need to take further, you need to do further investigation or take it more serious or admit the patient. Now for exacerbation of COPD. So core symptoms, dyspnea, onset, progression, baseline. So out of all and everything that here matters is this part. Very important. We all know about dyspnea, we know about the cough, chest tightness, and this and that, right? So if the patient has this, then the next step for us is to cover COCA-B. COCA-B, I think I have it here. Yeah, it is here. So we will talk about it. So COCA-B. And also, if my patient is having shortness of breath and the patient has cough, what is the first thing that I need to do? Safety for myself and my team. What do I have to ask for? Safety gears. I have to ask for the goggles. I have to ask for the mask. I have to ask for the gloves. I have to ask for the gown. Not only for myself, for my team, if I have any nurse accompanying me in that station. You just mention it. They're not going to give you anything. Just mention it that I need these because the patient is coughing and the patient is having, for example, vomiting, or the patient has continuously uh, ejecting sputum. So I want to just make sure that we are safe. Or if the patient has meningitis. So dealing with something as infectious as meningitis, you need to save yourself first. Then the next step is safety of the patient. So COCA-B. For any discharge from your body, you need to cover COCA-B. The COCA-B is, C stands for color. Like if it is sputum, what is the color of the sputum? O, odor. How does it smell? And C, consistency. Is it liquidiform? Is it hard? What is the consistency of whatever it is? If it is vomit, if it is sputum, whatever it is. And amount. How much is it? Is it less? Is it more? And does it have blood? So COCA-B for any discharge from the body. Just memorize it. All right. So severity screening. Can you speak? We all know this. We did it with the asthma. So same thing with the COPD. Confusion, drowsiness, and morning headache. It means the patient has CO2 retention. Chest pain, syncope, and cyanosis trigger clues. Usually the triggers could be the viral, it could be medication, smoking, environmental exposure, aspiration, and using some sort of medication like sedative and opioids. Can't miss because these are mimicking. So I think we did cover all of this in the previous slide, so I'm gonna skip. So I'm gonna come all the way here. The cardinal sign for the COPD that you need to know is dyspnea. For exacerbation, dyspnea will increase, sputum volume will increase, and sputum prolence is an indication for using antibiotic. So if the patient has cough, dyspnea, and the patient has sputum or the amount of sputum increased or the color is changed, antibiotic. All right, I don't see anything here new. Non-COPD baseline, nowadays worsening dyspnea, sputum color, triggers, frequency relief. So we did cover all this. So coca-B, I think we did cover it. For any discharge, please use the coca-B. So if the patient says that I have, for example, uh, I have a, for example, eye discharge. So if the eye discharge is, if you have an eye discharge or ear discharge, so what is the color? What is the odor, the consistency, the amount? Does it have blood? And so on and so forth. Okay. And thank you very much.